Hi, this is Dr. Pat Rush presenting a short video on the Iceberg Metaphor, a teaching tool for medical science. What can we as clinicians learn from the iceberg metaphor? The iceberg is, in fact, a system. What we see above the surface is only part of what's going on with the iceberg. The processes and structures below the surface seem invisible. However, when we see the top of an iceberg, we know that a deeper process is involved. Likewise, when we diagnose a clinical syndrome, we know there is deeper brain-body dysregulation. Before we go further, let's have a short reflection. Can you think of one medical or psychiatric diagnosis that the iceberg metaphor might apply to? Beneath overt surface manifestations, what underlying processes might be involved in that diagnosis? Such processes are often not looked for and therefore not seen, and therefore not taken into account when trying to understand the iceberg. Let's explore this metaphor further. Medical diagnoses are understood primarily as based on the patient's overt symptoms. These overt, above the surface findings are visible to the patient and to others such as families, teachers, and us as clinicians. Scientifically, these medical diagnoses are correct, but they are incomplete. Medical diagnoses are based on standardized pattern recognition of symptoms, findings on clinical exam, and diagnostic results. However, beneath the surface, invisible to others, and perhaps misunderstood, are the deep processes that result in the overt symptoms that we can see. Patients may have many symptoms that they cannot name, don't share with others, including clinicians, unless we specifically ask, and also don't recognize as being connected to the main problem. So how can we use the iceberg metaphor? The metaphor can help us improve diagnostics and therapeutics. We need to remember that what appears above the surface is only part of the problem. If we limit our medical and psychiatric diagnoses to surface observations, our diagnoses are incomplete. If our treatment focuses on changing only the surface symptoms, it is unlikely we will address the real problems, and our treatment plans will not be effective. We need to ask, is this the best that we can do? Let's apply the iceberg to cognitive and behavioral problems. With these problems, the symptoms are often distressing and may disrupt the classroom or the family. The caregivers and often the patient want these symptoms to stop. Medication seems like the answer because it will sometimes stop the overt symptoms. However, as we know, below the surface, there are many processes that seem invisible because they have not yet been assessed. Without a comprehensive assessment, the clinical symptoms may be misunderstood. Deep regulatory processes are often not amenable just to medication. Medication may actually cause more regulatory disruption, which we label as side effects. Treatment often requires skill building to improve regulation and may require trauma processing. Let's think broader. Training in how to identify and evaluate system dynamics allows us to appreciate the etiology of the patient's clinical problems and to improve our plan. By understanding the deep physiologic mechanisms behind the appearance of disease, we can appreciate pathogenesis. In other words, where the disease or the symptoms came from. A robust understanding of the disease process allows us to improve our therapeutic plan. We can identify problems earlier. Our diagnoses will be more accurate, and we can be more cost-effective by avoiding unnecessary diagnostics, including specialty evaluations and costly invasive tests. Our therapy can be more effective because we are addressing root problems. We will have a better anticipation of the course of a disease and help us track signs of healing or of worsening. Let's look at two examples. The first is a typical cognitive behavioral profile. A patient is diagnosed with multiple problems such as ADHD, reactive attachment disorder, oppositional defiant disorder, and PTSD. The treatment plan is usually limited to medication, with one or more medicines directed at each individual symptom cluster, like anxiolytics, stimulants, mood stabilizers, and antipsychotics. A different diagnostic approach would be to do a comprehensive assessment, including regulatory processes, particularly sleep, and history of the patient's early childhood. A comprehensive assessment may find that the patient, yes, has attention problems, but is best understood as having had developmental trauma from abuse or neglect. A sleep assessment may find that the child has a severe sleep disorder, perhaps nightmares. Some of what is being called attention problems may actually be dissociation in response to previous trauma. This dissociation may be reflected in episodes of spacing out. The patient may experience derealization or depersonalization, having out-of-body experiences. We may find that the patient has more developmental delays in several domains, not just behavior. And although somatic symptoms are often not identified, we may find that the patient has generalized autonomic imbalance with dysregulation of the GI system, the bladder, and others. Our expanded plan, based on a more comprehensive assessment, will focus on regulation with equal attention given to improving symptoms, not just stopping unwanted behaviors. We want to enhance positive feelings and behaviors. We might consider somatosensory therapy, including mindfulness. We would focus on sleep, improve a regular pattern of eating, bowel, and bladder, and increase safety and consistency in relationships. Let's look at a second example, asthma. This is a common physical problem. On the left, we see the typical diagnoses. When asthma is difficult to control, the clinician's first thought is often that the patient and family are non-compliant with medications. Also, if we continue looking outside the patient and family, we might focus on looking for possible environmental exposures that could provoke airway spasm. We want to note that with physical problems, we have kind of a reverse of the problem of assessment of patients with cognitive behavioral problems. When emotional problems are assessed, physical symptoms are often ignored. With physical problems such as asthma, psychological and behavioral problems may coexist, but are thought to be irrelevant to asthma rather than a clue to underlying problems. The typical treatment plan for asthma focuses on medication. A more comprehensive assessment recognizes asthma, but inquires deeply into sleep, autonomic imbalance, particularly difficulties with swallowing, with reflux of GI contents up into the patient airway. It's very important to assess family environment, hoping for feelings of safety and calm, but often finding chaos, distress, and anxiety. Regarding treatment, yes, of course. When someone is actively wheezing and short of breath, we would prescribe the same medications. But at the same time, we would focus equal attention on regulation, particularly sleep, and enhancing positive feelings and behaviors with increasing sense of safety and consistency in relationships. Thanks very much for joining us.